Good evening, everyone, and thank you for joining the American College of Foot and Ankle Orthopedics and Medicine for our latest billing and coding webinar titled The Appropriate Use of Modifiers in Podiatry. Tonight's webinar is presented to you by ACFAOM Fellow Dr. Michael G. Warshaw. My name is Angelica Tom, and I am the college coordinator. Before I introduce Dr. Warshaw, there are a few housekeeping tips I would like to go over. Just 1 second, audience. My apologies. Here we go. Tonight's webinar is being recorded. Participant lines will be muted during the entire live broadcast. However, we will ask question and answers towards the end of today's session. If you have any questions for the speaker at any time, please feel free to type them in the question box, which is in your webinar dashboard, and they'll be answered at the end of the broadcast. If you would like, Dr. Warshaw has provided a handout of tonight's slide deck so you can follow along and take notes. That is located in the handouts pod of your webinar console. If you should have any technical difficulties during this session, please contact me by using the chat box or the questions box, whatever works for you. Or you can also email me at atom, so that's ATOM, at paimgmt.com. After today's program, within the next few hours, you will receive an email from ACFAOM with the archive of the recording, as well as an online evaluation. Your feedback is very important to us, so please go ahead and fill that out. If you're interested in completing the survey right now, well, not right now, you haven't heard the program yet, you're welcome to click on the handouts pod, and there's a link that says survey, and it'll take you to another link for the online evaluation. Now let's get to the good part of this particular session. It's my pleasure to introduce Dr. Warshaw, who has an extremely impressive resume. So Michael G. Warshaw, DPM, FACFAOM, CPC, is a practicing podiatrist and certified professional coder with over 25 years of successful coding, management, and training experience for podiatric practices. His local and national views come from active participation as a practicing podiatrist, having the distinction of being a certified professional coder with years of serving as a national lecturer concerning coding issues. Dr. Warshaw's experience is unique and comprehensive. He has had the additional advantage of participating in all facets of the Medicare appeals process, including redeterminations, reconsiderations, and administrative law judge hearings, as well as the appeals processes of most commercial insurance companies and state Medicaid programs. Dr. Warshaw has also served as an expert witness in the actual court system at both the federal and state levels. This unique perspective provides Dr. Warshaw with the ability to provide solutions to insurance and coding problems from the real-world experience. Dr. Warshaw is committed to assisting practices in learning to code appropriately, obtain the proper reimbursement, and to avoid the wrath of the carriers by coding and billing in an appropriate fashion. Now, it's my pleasure to turn the program over to Dr. Warshaw. I'm just going to put up his slide deck right now, and we will proceed. Dr. Warshaw, please take it away.
Thanks, Angelica. Is there any way that you can move that thing off the right side of my screen, or can I do it?
You can do it. Go ahead and click the little arrow, the red arrow at the very top.
Got it. Thank you very much.
Thank you.
Well, ladies and gentlemen, hello. I'm very, very pleased that you were able to join us in the presentation of the appropriate use of modifiers in podiatry. The use of modifiers has been established to allow reporting of services that have been modified by some particular factor. It is imperative to be familiar with the requirements for each modifier and how to apply them to a particular situation to assure you are receiving appropriate payment for your services. As time has gone on, Medicare, the Office of the Inspector General, has really gotten involved in modifier use. The inappropriate use of modifiers or the use of the wrong modifier can allow for payment in situations where we ordinarily should not have been paid. And Medicare is very, very concerned about this, and they want to make sure we're getting paid in an appropriate fashion. Two of the modifiers in question that have really been raising an issue with Medicare lately have been modifiers 25 and 59. So I guess you could probably say they are the most important modifiers. What has been happening lately with audits with Medicare is that when you use the 25 and the 59 modifiers, and say for argument's sake you use them inappropriately, even if you're not getting paid a nickel more than you're supposed to get paid, Medicare is taking the position that even though you're not getting paid, the fact that you use them inappropriately is an attempt on the provider's part to obtain money in a fraudulent fashion from the government. So even though you're not benefiting in any way, you're in trouble. So those two modifiers are really at the top of the list, but there are quite a number of others that we have to use appropriately as well. Angelica, if you can move ahead a slide for me.
Certainly.
Actually, this is perfect. The first modifier in question is the 22 modifier for increased procedural services. As a rule, this is not a modifier for podiatrists to use. Podiatry, in general, is an elective type of situation when it comes to surgery. Better than 99% of the procedures that we perform as podiatrists are classified as elective. They are not mandatory. They are not life-saving. When it comes to certain medical specialties, such as general surgery, cardiovascular surgery, neurosurgery, and thoracic surgery, patients undergo lengthy, very long-term, life-saving, mandatory procedures where something can occur during the course of that procedure, necessitating the surgeon to vary the procedure from how it is classically described in the textbook, perhaps using an increased procedural service to complete the procedure to save the patient's life. It is a mandatory situation, and in such situations as that, you can make an argument for an increased procedural service. Not so in podiatry as a rule, because the majority of what we do is classified as elective. If it normally takes 45 minutes for a podiatrist to perform an Austin bunionectomy, but on this particular day, everything conceivably possible that could go wrong does, and it takes the podiatrist 3 hours to do the Austin bunionectomy, I guess you could possibly make an argument for the fact that increased procedural services were utilized. But at the end of the day, what was the end result? An Austin bunionectomy, the 22 modifier would not apply. Anytime you use the 22 modifier, you're going to be audited, and more than likely in a prepayment situation. It would be very difficult in the profession of podiatry to justify the use of this modifier. The 24 modifier, on the other hand, for an unrelated E&M service during the postoperative period, is a wonderful modifier. In fact, it is such a wonderful modifier that every year when the Office of the Inspector General comes out with what they are going to target for fraud and abuse for the upcoming year, the inappropriate use of the 24 modifier always ranks in the top 5. I'm not saying you shouldn't use it. You should use it, but you have to know how to use it correctly. You use this modifier only on an E&M code when you perform an evaluation and management service during the follow-up period of an unrelated surgical procedure. Key phrase, unrelated surgical procedure. You are entitled to bill for an E&M service performed during the follow-up period if that service is not related to the original surgical procedure. In this case, you add the 24 modifier to the E&M service code, and you make sure you reference this service code to the appropriate unrelated diagnosis on the billing claim. Illustrative example. A patient has an Austin bunionectomy performed on her right foot. 4 weeks into the post-op global period, she goes in to have that surgical foot checked. Everything is doing fine with the Austin bunionectomy, but the patient has a new problem. Her left heel is killing her. Clearly, it has nothing to do with the surgery that was performed on the right foot. The doctor does the appropriate history, physical examination, and medical decision-making and finds that the patient has plantar fasciitis of the left foot. The doctor decides to prescribe an oral anti-inflammatory medication. This justifies billing a Level 3 established patient E&M service, a 99213, which goes on line 1 of the claim form with the new unrelated diagnosis, plantar fasciitis, M72.2. In order to get paid for that 99213, you need a modifier, and that would be 24 for that unrelated E&M service during a post-operative period for another issue. Well, let's make this a little more interesting. The doctor decides to x-ray that left foot, the new problem foot, 73620 or 30 with an LT modifier with the new diagnosis code M72.2, plantar fasciitis. The doctor then decides to give a cortisone injection into that left heel. 20550 with an LT modifier goes on line 3 with the associated diagnosis plantar fasciitis M72.2. As soon as that injection is administered, we've created 2 problems. Problem number 1. If Medicare has a modifier for an unrelated E&M service during the postoperative period, wouldn't you suspect that they also have a modifier for an unrelated procedure during the postoperative period? Angelica, if you can just flip a few slides ahead. Keep going. One more. There we are. No, go back one. And stop right there. The 4th one up from the bottom is the 79 modifier for an unrelated procedure by the same physician during the postoperative period. So line 3 would read 20550 LT 79. Now, if you can go back to the first one in the process, that would be good, Angelica. Perfect. No, perfect. But I said it created 2 problems. Here is problem number 2. That 24 modifier got you paid for that unrelated E&M service during that postoperative period. But as soon as you administered that injection, a minor surgical procedure code, we've created a situation where an E&M service is being performed in conjunction with a minor surgical procedure. In order to keep that E&M service, you need another modifier to go on that E&M service, and that will be the 25 modifier. So very basically, the coding sequence that we just discussed, line 1 will be 99213, 24, and 25 modifiers. Line 2 would be 73620 or 30 for the x-rays with the LT modifier because the x-rays are on the left foot. And line 3 would be 20550 LT and 79 modifiers. The mention of the 25 modifier segues us to its appropriate use. This is an important modifier, extremely important. The 25 modifier is for a significant separately identifiable E&M service by the same physician on the same day of a minor surgical procedure. It's extremely important simply because Medicare feels the following. Every procedure code, every CPT code has an inherent E&M component to it. It's built in. Thus, Medicare does not want to pay you for billing an E&M service and a procedure on the same date of service. But the rules and regulations allow this to be done. So what has to be done through the documentation of the physician is that this documentation needs to demonstrate the physician's thought process, whereby he or she can demonstrate how they appropriately extracted that E&M component from within that minor surgical procedure code. And with the next three examples, which are the three ways that you can bill an E&M service with a minor surgical procedure, I will show you how with specific examples. The 25 modifier is used to demonstrate that a significant separately identifiable E&M service was performed on the same day of a minor surgical procedure by the same physician. Once again, key phrase, significant, separately identifiable, E&M service. If a physician, a provider, is audited by Medicare specifically for the inappropriate use of the 25 modifier, what you will find in the comment box every time Medicare rejects the use of the 25 modifier, it would say, failed to demonstrate that a significant separately identifiable E&M service was performed. The 25 modifier is only used on an E&M service. It's E&M specific. An initial E&M service can be billed when performed on the same date of service as a minor surgical procedure code. The diagnosis code for the initial E&M service and the diagnosis code for the minor surgical procedure can actually be the same. The question is why? You've never seen this patient before. It's a new patient. The physician does the appropriate history, physical examination, and medical decision-making, the three key components that make up an E&M service, and comes up with a working diagnosis that demonstrates medical necessity. If that diagnosis can be treated medically, then you would bill the appropriate initial E&M service. But based upon that diagnosis that you have come up with, you decide to treat that issue or diagnosis procedurally, you may be able to bill both the E&M service and the procedure. And since they are both new issues, the diagnosis code for the E&M service and the procedure can be the same. Illustrative example. Once again, we have a patient complaining of pain in her right heel. The doctor does the appropriate history, physical examination, and medical decision-making, and finds that the patient has plantar fasciitis of the right foot, is able to justify billing a Level 3 initial patient E&M service, a 99203, which goes on line 1 of the claim form with the associated diagnosis, M72.2, plantar fasciitis. The doctor x-rays that right foot, 73620 or 30, with an RT modifier, goes on line 2 with the associated diagnosis again, plantar fasciitis, M72.2. The doctor decides to administer a cortisone injection into that right heel. 20550 with an RT modifier goes on line 3 with the diagnosis code M72.2 plantar fasciitis. On line 1 we have that 99203. On line 3, we have the 20550. In order to be paid for that 99203, you need a modifier, and of course, it's 25. An established patient E&M code can be billed when performed on the same date of service as a minor surgical procedure code. The diagnosis code for the established E&M service must be different from the diagnosis code for the minor surgical procedure. There can be absolutely, positively, unequivocally no correlation between the E&M service and the minor surgical procedure. Illustrative example. That same patient comes back 2 weeks later. How's your right heel? It's killing me. The doctor does a history. When does it hurt? It hurts when I first get up in the morning and I step down. It hurts when I'm sitting for a while and then I go to stand up. The doctor does a physical examination, pushes on the bottom of the heel. The patient jumps, squeezes the sides of the heel. The patient kicks. The patient has plantar fasciitis, hasn't gone away. The doctor decides to give the patient a prescription for an oral anti-inflammatory medication, is able to justify billing a level 3 established patient E&M service, a 99213, which goes on line 1 of the claim form with the diagnosis code M72.2, plantar fasciitis. Pretty straightforward. End of story. But then the patient turns to the doctor and says, "Doctor, since my heel is hurting me so badly, can I get another injection?" I hope everybody understands that as soon as that decision is made to give that second injection, you no longer can bill that 99213. Why? Because it is directly established. It is directly related. You can't make an argument otherwise. You need to pitch that 99213, and now on line 1, you bill the 20550 with the RT modifier with the diagnosis code M72.2, plantar fasciitis. And that is the only thing that you can bill for. That E&M service is now part of the minor surgical procedure code. You cannot separate it out. But then the patient turns to the doctor again and says, "Doctor, while I'm here, I have another problem. My left big toe joint is throbbing." Never mentioned the left big toe joint. Never examined the left big toe joint. Never treated the left big toe joint. New problem, established patient. The doctor does the appropriate history, physical examination, and medical decision-making and finds that the patient has painful hallux valgus of the left foot. Wouldn't that oral anti-inflammatory medication that was prescribed for the right heel work great for this problem? You need to document that exactly like that in the medical record. As soon as you do that, you can qualify billing a level 3 established patient E&M service, a 99213. You take that injection code for the right heel that's on line 1 and you put it on the side. Now on line 1 you put that 99213 with new diagnosis M20.12, hallux valgus of the left foot. You're going to x-ray the left foot. Why wouldn't you? 73620 or 30 with an LT modifier goes on line 2 with the new diagnosis, hallux valgus left foot, M20.12. You're going to take that injection code for the right heel, and now you're going to put it on line 3. 20550 with an RT modifier goes on line 3 with the original diagnosis, plantar fasciitis, M72.2. On line 1, you have the 99213. On line 3, you have the 20550. In order to get paid for that 99213, you need a modifier, and 25 is the one. Why can you do this? Because the diagnosis code for the established E&M service is clearly different from the diagnosis code for the minor surgical procedure. And there is absolutely no correlation between the E&M service and the minor surgical procedure. Last point. If an established patient is seen for a new problem that the patient has never been evaluated for previously, and a minor surgical procedure is performed on the same date of service, then not only can both the established patient E&M service code and the minor surgical procedure code be billed for, but the diagnosis code for the E&M service and the diagnosis code for the minor surgical procedure can actually be the same. And of course, this needs to be thoroughly and accurately documented in the medical record. That same patient comes back 2 weeks later. How's your right heel? It's fine. How's your left big toe joint? Doesn't bother me anymore. Call me if you need me. The patient comes back 2 weeks later. The patient comes back 2 months later. The patient comes back 2 years later. The patient can even come back 2 days later. Quite honestly, it can actually be the same day. Doctor, I have a new problem. My left heel is killing me. Never mentioned the left heel. Never examined the left heel. Never treated the left heel. New problem, established patient. The doctor does the appropriate history, physical examination, and medical decision-making and finds that the patient has plantar fasciitis of the left foot, is able to justify billing a level 3 established patient E&M service, a 99213, which goes on line 1 of the claim form with the diagnosis code M72.2, plantar fasciitis. You're going to re-x-ray that left foot. Why? It's a new problem. 73620 or 30 with an LT modifier goes on line 2 of the claim form with the diagnosis code M72.2, plantar fasciitis. The doctor decides to give a cortisone injection into that left heel. 20550 with an LT modifier goes on line 3. The diagnosis again is plantar fasciitis, M72.2. On line 1 is the 99213. On line 3 is the 20550. In order to get paid for that 99213, you need a modifier, and that will be 25. Spent a lot of time on this. This is important. Next slide, please, Angelica. 26 modifier, professional component only. You use this modifier when you are only billing for the physician component of a service, such as x-rays. This is a modifier that is going to be used very, very infrequently in podiatry. Professional component only. When it comes to x-rays, as a rule, podiatrists take x-rays in an office setting. When you take x-rays in the office setting, they generally are billed the following way: 73620 or 30 with either an RT or an LT modifier appended to them. When x-rays are billed in such a fashion, it is assumed that both the technical as well as the professional components are both performed. The technical component of the x-ray service has two parts: the physical taking of the x-ray and the developing or the processing of the x-ray. The professional component of the x-ray service also has two parts: the interpretation of the x-ray and the generation of an x-ray report. Both are assumed to be performed if you're billing for an x-ray service and the only modifiers that are being used are the anatomical modifiers. The 26 alone is something not used very often in podiatry. The 32 modifier for mandated services does not apply. The 50 modifier for a bilateral procedure. A bilateral procedure is the exact same procedure being performed on both extremities. If a the same exact procedure is being performed on the same toe on both feet, that is not considered to be a bilateral procedure. There are toe modifiers that we are instructed to use whenever a procedure is performed on a toe. Thus, a bilateral procedure is the exact same procedure being performed on both feet, but not on a toe. There are two ways to bill a bilateral procedure. You can bill it on one line. You list the CPT code, you append the 50 modifier, bill it at 1 unit because the 50 implies 2 units, and you double the price of what you would charge if you were doing the procedure once. Or you can bill it on 2 lines. Line 1, you list the CPT code, append the RT modifier, and bill it out at full price. On line 2, you list the CPT code, append the LT modifier, and bill it out at full price. Either way is supposed to be correct. But as a rule, unless Medicare directs you to perform it one way or the other, Medicare kind of likes when you bill a bilateral procedure on one line with the 50 modifier, and you double the price. 51 multiple procedures. It took Medicare many years to finally realize how ignorant this modifier is. In order to use the 51 modifier, you have to be in a multiple procedure scenario. You have to be performing more than one procedure. Let's say, for argument's sake, the podiatrist is performing 2 procedures on a patient. On line 1, you list the CPT code. On line 2, you list the CPT code with the 51 modifier appended to it. This way, anyone that's reviewing the claim would say, oh, since I see a 51 modifier appended to that second CPT code or procedure code, obviously you're doing 2 procedures that day. Well, it took Medicare years to realize that unless the person reviewing the claim was either blind or illiterate, wouldn't you see 2 codes written or documented one under the other without having to append the 51 to the second one telling you to look at it? You don't need the 51 modifier with Medicare unless you get a claim rejected and they tell you you need the 51. As ignorant as it is, if they tell you to do it, you do it. But as a rule, you don't need it. Certain commercial insurers want you to use it, but they can be pretty ridiculous also. Let's say you're in a multiple procedure scenario. You don't append the 51 modifier to the second CPT code. You send your claim in to be processed. You get paid exactly what you're supposed to get paid for doing both procedures. But when you look at the EOB, they correct the way you sent in the claim. They append a 51 modifier to your second procedure to let you know, by the way, did you know you did 2 procedures? It's ridiculous and absurd, but as a rule, you don't need it. The 52 modifier for reduced services and the 53 modifier for discontinued procedure are 2 modifiers that are used rarely. But every so often, someone will ask me for an example of both. Here's an example. A patient is walking in her house barefoot on a wooden floor, and it really wasn't finished, and she feels a sharp pain. She's convinced she has a splinter that went into her heel. She goes in to see a podiatrist, and the podiatrist locally anesthetizes the area and tries to remove the piece of wood from her foot in the office. He couldn't find it to remove it. The podiatrist feels that it would be best to take the patient the next day to the ambulatory surgical center to use the fluoroscopy unit to identify the foreign body and remove it from the foot. But why shouldn't you get paid for attempting to remove this piece of wood from the foot, despite the fact you couldn't find it. You performed the procedure. You did it under local anesthesia. You would bill the appropriate removal of foreign body code. You would append the 53 modifier to it for a discontinued procedure, and your documentation would support the fact that you couldn't find it and you were continuing it the next day in the surgical center. So the next day, the patient goes to the ambulatory surgical center, receives MAC anesthesia. The podiatrist additionally locally anesthetizes the area, uses the fluoroscopy unit, probes around for a pretty extensive period of time, and amazingly, there is no foreign body. There is no foreign body to remove. But the doctor went through the entire process of removing the foreign body. And this will be documented in your op report and in the medical record. You would bill the appropriate removal of foreign body code. You would append the 52 modifier to it for a reduced service, and that will get you paid. One other modifier should be used. On that first day, when the doctor could not find the foreign body in the office and billed with the 53 modifier for a discontinued procedure, since there is a 10-day global period for the removal of a foreign body, it would probably be appropriate to also append the 58 modifier for a stage-related pre-planned procedure the next day when the fluoroscopy unit was used and there was no foreign body. So on day 2 in the ambulatory surgical center, you would bill the appropriate removal of foreign body code. You would append the anatomical modifier, the 52 modifier for reduced services, and the 58 modifier for stage-related pre-planned procedure, and we will get there shortly. In the realm of possibilities, in a prearranged, pre-established scenario where it's all or nothing, and the two physicians involved are not related professionally in any way. They are not partners. They are not in the same group. They do not share the same tax ID number. They are not of the same specialty in a multi-specialty situation. Two doctors can be involved in the surgical procedure performed on a patient, where one doctor does the surgery and none of the postoperative care, and another doctor does not participate in the surgery and does all of the postoperative care. The doctor that is doing the surgical procedure only and none of the postoperative care would bill out the procedure at full price, append the 54 modifier to it, and his or her reimbursement would be 65 to 80% of the global reimbursement, because that is what the surgical component pays. The doctor that is not participating in the surgery and does all of the postoperative care would bill out the procedure at full price, append the 5 modifier to the CPT code, and his or her reimbursement would be the remaining 20 to 35% of the global reimbursement, because that is what the postoperative component pays. Pre-planned, pre-established, all or nothing, the two doctors involved cannot be related professionally at all. The 56 modifier does not apply. The 57 modifier is classified as the decision for surgery. Modifier 59 is used to identify an E&M service provided on the day before or day of surgery, in which the initial decision is made to perform major surgery, 90-day post-op global period surgery. The global surgery policy includes the E&M service provided, next slide please, on the day before or day of the major surgical procedure unless the E&M service resulted in the decision to perform surgery. The bottom line is, when a minor surgical procedure code is performed in conjunction with an E&M service, a 25 modifier goes on the E&M service. When a major surgical procedure is performed in conjunction with an E&M service, a 57 modifier goes on the E&M service. The reason that the description of this modifier talks about the day of or the day before the surgery is performed, that is because for a 90-day post-op global period major surgical procedure, the global period starts not the day of the procedure, not the day after the procedure, but the day before the procedure. The 58 modifier is for a staged or related surgical procedure. The key phrase which you have to present either in your op report or in the medical record documentation is that you are in a staged, related, pre-planned scenario. Here is another illustrative example, a little more specific. You have a patient that is an out-of-control diabetic. This diabetic patient has a horribly infected foot. In fact, it's osteomyelitic and it's gangrenous. The patient, unfortunately, is going to have to undergo a transmetatarsal amputation. The patient is taken to the OR, and during the course of the amputation, the surgeon realizes that the infectious process is so significant that delayed closure is going to have to be performed at point X in the future. You need to make reference to that fact in both the op report and in the medical record of that patient. You're doing that because you're creating a staged-related pre-planned scenario. When point X in the future comes and that surgical site is going to be closed, you bill the appropriate wound closure code, you append the 58 modifier to that second, the staged related pre-planned procedure, and that will get you paid. Not only does it get you paid, it gets you paid full price. Not only does it get you paid full price, but that second procedure does not reset a new 90-day post-op global period. Why? Because on that initial surgical procedure encounter, when you state that you have a stage-related pre-planned scenario, it's not a complication to the original procedure when you do that second procedure. It's not an unrelated procedure to that original surgical procedure. You're telling them it's a continuation of the original surgical procedure, and you're stating why the procedure had to be stopped and continued at point X in the future. And that is why they pay you full price for the second procedure, and that is why it doesn't reset a new 90-day post-op global period. The next modifier, the 59 modifier, probably is the most important modifier. I've always warned about audits for the 59 modifier. This is a horrible audit. They will cite you for using it inappropriately, even if you don't get a nickel more in reimbursement. Under certain circumstances, it may be necessary to indicate that a procedure or service was distinct or independent from other non-E&M services performed on the same day. Modifier 59 is used to identify procedures or services other than E&M services that are not normally reported together but are appropriate under the circumstances. Key words in that first paragraph: distinct, independent. Documentation must support a different session, different surgery or procedure, different site or organ system, separate incision or excision, separate lesion or separate injury or area of extensive injuries not ordinarily encountered or performed on the same day by the same individual. Keywords in that second paragraph: different, separate. But the next sentence is the key. However, when another already established modifier is appropriate, it should be used rather than modifier 59. Many of us are under the impression that the 59 modifier should be the modifier of first choice. In reality, it is the modifier of last resort. Only if no more descriptive modifier is available, and the use of modifier 59 best explains the circumstances, should modifier 59 be used. Thus, the doctor or the doctor's designated appointees, the billers and the coders, have a due diligence. You have to do a modifier search to make sure another modifier should not be used instead of modifier 59. So the question is, how does Medicare know that you are using the 59 modifier appropriately? Well, they have a 4-bullet punch list for the correct use of the 59 modifier that is part of their software. It's an all-or-nothing proposition. You have to take any CPT code that you anticipate or want to append with the 59 modifier and run it past these 4 bullets, because that's what Medicare does. If it passes all 4 bullets, you can use the 59 modifier. The 59 modifier is only used on a procedure code, never on an E&M code. Thus, it is a procedural modifier. The procedure code in question is a distinct or separate service from the other services performed on the same day. So not only is it a procedural modifier, it is a distinct procedural modifier. The 59 modifier serves as an anatomical modifier. Why? Because there is not available a true anatomical modifier to show the carrier that the procedure code in question is a separate service from the other services performed on the same day. And the 59 modifier is a multiple procedure modifier. Thus, in order to use it, you have to be performing and billing for at least 2 procedures. The 59 modifier doesn't go on both. It goes on the second procedure. It doesn't go on the second procedure based upon which procedure pays the most. It goes on the second procedure based upon how the 2 procedure codes are listed in the correct coding initiative. The 59 does not go on the column 1 code, it goes on the column 2 code. So to make your evening or afternoon even more complete, we are also responsible to know the correct coding edits for every CPT code that we bill. If your software does not do this for you, you're going to have to be able to access the CCI edits. Let's do an illustrative example. A patient has 2 surgical procedures performed on her right foot. She has an Austin bunionectomy performed on the first ray, and she has a Weil osteotomy performed on the second metatarsal. The Austin bunionectomy is billed on line 1, 28296 RT modifier. The Weil osteotomy is billed on line 2, 28308 RT modifier. If you bill in such a fashion, you're going to be performing that Weil osteotomy for free. So the question is, should that 28308 be appended with a 59 modifier? Quickly, you look at the 4 bullets. Clearly, 28308 is a procedure code. It hits the first bullet. The procedure code in question, 28308, is a distinct or separate service from the other services performed on the same day. The 28308 was performed on the second metatarsal. The the 28296 was performed on the first metatarsal, so it hits the second bullet. Is there available a true anatomical modifier to show the carrier that the procedure code in question, 28308, is a separate service from the other services performed on the same day, the other service being 28296? We have toe modifiers, we have foot modifiers. We don't have metatarsal modifiers. Metatarsals are considered to be part of the foot, not part of the toe, so it hits the third bullet, and clearly we are in a multiple procedure scenario, so it hits all 4 bullets. The appropriate way to code the scenario would be line 1, 28296 RT, line 2, 28308 59 RT. Whenever you use the 59 modifier, it is most appropriate to put it first. It is the only time a numeric modifier will precede a letter modifier. And the reason that the 59 goes first is because you're telling Medicare it is the superseding modifier for that CPT code. And in the event of an audit, your medical record documentation will demonstrate that all 4 of those bullets have been met. Next slide, please, Angelica. The 62 modifier is for 2 surgeons, and while it does apply, it is not utilized very frequently. The 76 and the 77 modifiers are truly not used very often at all. Most of the time, they serve as response modifiers. Here's an example. The 76 being repeated procedure by the same physician, the 77 repeated procedure by another physician. A patient has a very painful ingrown toenail on her right great toe. She goes to see a podiatrist, and the podiatrist does excision of nail and nail matrix tibial border of the right great toe and bills 11750 T5. 10-day global, patient heals, no problem. 4 weeks later, the other side of that toenail, the fibular border, becomes ingrown and painful. She goes back to the podiatrist, and the podiatrist does excision of nail and nail matrix fibular border of the right great toe and bills 11750 T5. You send the claim into Medicare, and Medicare rejects the claim. You just did this procedure 4 weeks ago. You can't bill for it again. Medicare has no idea that it's the other side of the same toenail. You have to tell them. You need to rebill. 11750 T5 76. Repeated procedure by the same physician. But this is not enough. You need to give them more information, and there is not another modifier that can do that. You need to go up to Block 19, or the electronic equivalent of the CMS 1500 claim form. This is the information block, and you print out same toe, opposite border, and that will get you paid. The 77 modifier is essentially the same, except the second procedure is performed not by the same physician, by another physician. The 78 modifier is unplanned return to the operating or procedure room by the same physician following an initial procedure for a related procedure during the postoperative period. This is a very wordy way of saying complication modifier. Illustrative example. A patient has an osteotomy performed on a metatarsal. The doctor fixates that osteotomy with a screw or a compression plate. This hardware is never supposed to come out. During the 90-day post-op global period, a justifiable documented complication arises necessitating the removal of that hardware from that metatarsal. You bill for the appropriate removal of hardware code you append the 78 modifier to that CPT code, and that will get you paid. We already discussed the 79 modifier, unrelated procedure by the same physician during the postoperative period, in conjunction with the 24 modifier. 80 modifier, assistant surgeon. For certain designated procedures, a primary surgeon can bring an assistant surgeon in to help with the surgery, and for those designated procedures, that assistant surgeon can get paid. The reimbursement to the assistant surgeon is not very much. It's 16%, 16%. In order for the assistant surgeon to get paid, you bill the appropriate procedure code at full price, you append the 80 modifier to it, and that will get you paid 16%. The 90 modifier does not apply. The 99 modifier is the multiple modifier. You're rarely, if ever, going to use this modifier. Next to a CPT code on the claim form, either hard copy or electronic, are 4 spaces for modifiers. I doubt any of you have ever had the need to use 4 modifiers after a CPT code. You're not going to have to use 5. Next slide, please.
Certainly, Dr. Warshaw, and I just want you to be aware that it's presently 8:56.
I will be done in 7 minutes.
Very good.
GA modifier, not reasonable and necessary with an ABN. You use this modifier on a service or item code when you want to indicate that you expect Medicare to deny the service or item is not reasonable and necessary, and you have a signed advanced beneficiary notice of non-coverage and ABN on file. You should not submit a claim for a non-covered service, ever, unless the patient insists that you do so. So a new patient comes into the office and she wants her toenails cut. She doesn't have class findings and a systemic disease. She doesn't have symptomatic mycotic nails. She doesn't meet the coverage criteria. She is told this. She is instructed to sign an ABN, and she pays the fee. She has her nails cut, comes back up to the front desk, and instead of making another appointment, she says, listen, I want you to submit the claim. Maybe Medicare will make a mistake and pay. If the patient insists that you send in the claim, you're obligated to do so. You take the non-covered procedure code, hook it up with the non-covered diagnosis code, append the GA modifier to the non-covered procedure code, and both you and the patient will be notified it's a non-covered service. But if you ever send in a claim to Medicare and you forget to put the GA modifier on that CPT code for a non-covered service, not only will both you and the patient be notified that it's a non-covered service, but both you and the patient will be notified that you have to give the money back to the patient that you took for that non-covered service. In such a scenario, the only recourse that you have for not giving the money back would be to produce a copy of the ABN that you had the patient sign on that date of service. Thus, it is imperative to have an ABN signed anytime and every time you see a patient that receives a non-covered service. The GP modifier is the physical therapy services modifier. The GV and the GW modifiers are hospice service modifiers. When a patient goes into hospice, they have a terminal condition. And when they go into hospice, they lose their Medicare Part B benefits. While they're in hospice, they still may have the need for podiatric care. They may have painful mycotic nails. They may have an ulcer. They may have an ingrown toenail. They might have an abscess. When a patient sees when a podiatrist sees a patient in hospice and performs a service, you bill the appropriate procedure code. You append it with the GW modifier to indicate that the provided services are not related to the hospice patient's terminal condition, and that will get you paid. GY is for a non-covered service. As a rule, if Medicare doesn't pay, the secondary doesn't pay, and this is when the ABN comes in, and if the patient insists that you send a claim in, it's the GA modifier. Some patients have these really good secondary insurance plans that will pay even when Medicare doesn't. The onus is on the provider to check and make sure that secondary insurance is going to pay, because patients very often will say, my secondary will pay even though Medicare doesn't. Since Medicare is the primary insurer in one of these situations, and usually these people that have these really good secondary insurance plans tend to be retired government workers, you still need to get the rejection from Medicare. You take the non-covered diagnosis code, hook it up with the non-covered procedure code, append the GY modifier to the procedure code, send it into Medicare to get the rejection EOB. Either Medicare will send it on to the secondary insurance, or you will send that rejection EOB onto the secondary insurance with a new claim form with the GY modifier already processed to Medicare, and this will get you paid. GZ does not apply. KX is documentation on file, important modifier. Use this Medicare modifier to indicate that specific documentation is contained in the medical record to justify the billed service. This modifier is used on all line items for claims that are submitted to the Durable Medical Equipment Regional Carrier. This is the modifier that Medicare uses to reject your claims for diabetic shoes in a prepayment audit. LT is left foot, left side please. RT, of course, is right foot. Here are the class findings modifiers, Q7, Q8, and Q9. TC is technical component only. Here are the toe modifiers. And at 2 minutes after 9, that is the body of my presentation.
Terrific. Thank you, Dr. Warshaw. I know we're a little bit past audience on our schedule time. However, Dr. Warshaw is definitely one of our experts here in terms of all things coding and billing. And we do, if you'd like to stay on, and if you have any questions, feel free to ask them right now for those who are able to attend. If you're not able to attend, again, the webinar recording will be sent out to all participants. So if you have any questions, please write your question into the question box. I see that we have something coming in right now. Let me go ahead and open this up. And Dr. Warshaw, the question is, can a TC code be used on ABI, or can a podiatrist read the exam?
Well, here's the deal. It can be used on non-invasive vascular testing, and ABI is considered to be part of the E&M service, and it cannot be billed separately. But when it comes to vascular testing, and you're billing the codes, for example, 93922 or 93923, we as podiatrists do not, unfortunately, have the qualifications to interpret the test. We, though, can perform the test. So when you perform these vascular tests, the answer would be yes, you put the TC modifier on the 93922 or the 93923.
Great. Thank you, Dr. Warshaw. We do have another question. How do you bill nails and lesions together?
Well, unfortunately, you need to go in the correct coding initiative in order to see how to do that. But I will tell you, it's pretty straightforward. Once you do it once, it's going to be the same all the time. If, for example, you're billing 4 to 6 lesions, which would be 11056, and you're debriding 10 mycotic nails, which would be 11721, and you obviously need a Q modifier. Let's say it's Q9. I1 would be, 4 to 6 would be 11057, or more than 4. So let's say 11057, Q9 would go on line 1, and line 2 would be 11721, 59 Q9. The bottom line is the lesions are always billed first. They are the primary or column 1 procedure. The nails that are performed in conjunction with the lesions are always the secondary or column 2 procedures for the CCI edits.
Great. We have one more question here. It says, how do I bill for a neuroma injection on the right and left foot? I have received denials for coding 64455 RT and 64455 LT and 6445550, I believe.
Yeah, for bilateral. Here is the problem with that code. When you read the CPT description of 64455, it says injections with the S in parentheses, which means it can be one or more injections, anesthetic agent and or steroid, plantar commingeal nerve or nerves, for example, Morton's neuroma. So according to this, what they are pretty much telling us is that they only want to pay for one neuroma injection, the code 64455, on the same date of service. But I can make a suggestion, and it might be worth trying it. I would bill it on 2 lines. I would bill on line 1, 64455, RT on line 1. I would bill 64455 59 LT on line 2. I then would go up to block 19 on the CMS 1500 claim form or the electronic equivalent, and I would print out 2 separate anatomical structures injected. And I think you probably will get paid, but if you don't, I think you have excellent grounds right there for an appeal.
Excellent, Dr. Warshaw. We have another question, another couple questions that have come in. Are physical therapy codes payable to podiatrists? Should the PT modifier be used?
Well, the answer is yes. Physical therapy, as long as you have a plan of physical therapy established and you're not performing an isolated incident of physical therapy like ultrasound, like one time in a week, yes, you can get paid for physical therapy, and yes, we have to append the GP modifier, whether it's done by a podiatrist, a physical therapist, whomever. The GP is mandatory.
Thank you, Dr. Warshaw. Another question. Can you give examples for 59 modifier changes?
Yeah, I mean, you know, I'm sorry I didn't bring that up. It simply slipped my mind, but here is a factual response. Angelica, can you go back a couple of slides?
Sure. Hold on.
Stop right there. Right there.
All right.
Perfect. Okay. When Medicare came out with these changes to the 59 modifier, it created a great deal of confusion, which is obviously leading to the question I was just asked. It was so confusing that when CAC representatives went back to Medicare and they requested explanations of these X modifier subsets, the Medicare carriers didn't understand them themselves. So the X modifiers were put on hold. You don't have to use the X modifiers. When you get a hard copy directive from your Medicare carrier telling you when you have to start using the X modifiers and a start date, then you use them. We have all been instructed that you can use the X modifiers if you want to, but why would you want to? You can continue to use the 59 modifier as you always have, as long as you are using it in an appropriate fashion. No one has received the directive in hard copy from their carrier telling them to use the X modifiers yet. Continue to use the 59 until that occurs.
Thank you. Another question. Can you please explain KX codes again?
I'm sorry, what kind of codes?
It's a little KX.
Oh, KX. Got it. Okay. Here's the deal with the KX modifier. The KX modifier, we've learned over the years that we need to use it for diabetic shoes, and then followed by anything that is billed to your durable medical equipment regional carrier. But the real thing about this modifier is that what you're telling Medicare is that you're indicating that specific documentation is contained in the medical record to justify the code that you're billing. The problem is many people don't know the rules that are associated with billing for the diabetic shoes and the durable medical equipment supplies that we provide to our patients. So it's not a modifier that's a free pass to get you paid. It's really a modifier that's allowing Medicare to not pay you, because when you can't get paid without the KX for any DME item. But when you use the KX, you're telling Medicare that if they audit you, you will be able to provide from your documentation everything that they ask you about that's stated that you need to have for your documentation from the LCD for that supply. So really it's not a modifier to get you paid. They're using it to try not to pay you. It really means specific documentation is on file or contained in the medical record to justify what you're billing your durable medical equipment regional carrier for.
Thank you, Dr. Warshaw. We do have a couple of extra questions. Are you available to take them right now?
I will take two, and
okay.
Then I think it's time.
Yeah, agreed. So I'm going to take these last two questions. Audience, if you have any other questions, I ask you to just go to visit Dr. Mike's website. What is your website again, Dr. Mike?
Well, actually, what I would do, as opposed to the website, I'll just give you my email address, and I don't mind doing this. Just don't take advantage of the fact. It's my name. It's DR. No, actually, forget the DR. New one. It's MICHAEL, the letter G, Warshaw, WARSHAW, @gmail.com. It's my name. It's Michael G. Warshaw @gmail.com. It is not case sensitive.
Thank you. Okay, so we're going to take these last two questions. Can 29540 and 20550 be billed on the same foot?
No. Aside from the fact, number one, that on July 1st of 2006, ironically 10 and a half years ago, this rule went into effect nationally, that you cannot bill for either a foot and ankle strapping or the application of an UNA boot and an injection code on the same extremity on the same date of service. If you look at the correct coding initiative edits, those codes are all bundled together. You cannot bill for both of them on the same extremity on the same date of service.
Thank you. And this is our final question, audience. Again, if you would like to contact Dr. Warshaw after the show, he has kindly given his email address, which is michaelgwarshaw@gmail.com. However, please don't abuse it, but he will be happy to respond back to you. The final question is, Dr. Warshaw, can you speak briefly about diabetic shoes? This podiatrist was denied payment because the date the patient signed the shoe receipt was after the date that the doctor had billed for the shoes.
Repeat that question once again. It's confusing me.
Can you speak briefly about diabetic shoes? I was denied payment because the date the patient signed the shoe receipt was after the date that I had billed for the shoes.
Well, the bottom line is, if you read the LCD, the patient has to sign that they received the shoes on the date that they were billed. It's got to be the same day. That's the date of service.
Very good. I think we have met the end of our program here. Thank you, Dr. Warshaw. You truly are an expert when it comes to all things coding and billing, and are truly one of the most detailed men in the industry. The pages that you saw, audience, were from Dr. Warshaw's current edition of the Podiatry Manual on all things billing and coding. For your questions, it is extremely thick and very detailed, and he painstakingly ensures that everything is updated and you know, as it is at this present moment in time. If you are interested in learning more information about the book, you're welcome to go ahead and visit the ACFAOM .org website. There's also a link in front of you to information about the book. But it is time that we log off, audience. Thank you for staying for this extra time and for joining us for the appropriate use of modifiers in podiatry. Again, you will receive an email containing the recording of tonight's webinar, along with a link to an online evaluation. Really, your feedback is very important to ACFAOM, so please go ahead and complete this online evaluation. So that's basically it, audience. We thank you for joining us tonight. This concludes tonight's presentation, and you may now disconnect.